Now let's begin with the endocrine pathology. Primary focus has to be on thyroid gland. When I'm talking about thyroid, I'll first start with the adequacy criteria that you need to have on FNSC. So when you're doing an FNSC, this adequacy criteria has been given by an organization that is referred to as the Bethesda System of Organization. So the Bethesda group has given this, this entire adequacy criteria, and they say that at least 6 groups of follicles. So let me count this FNSC slide. One group, definitely one group of cells, second group of cells, third, fourth, fifth, sixth, seventh, many more than 6, right? So minimum of 6 group of cells of follicles should be seen, and every group should have how many cells? At least 10 cells per group should be present, at least 10. So I don't even need to count. Of course, there are more than 10 in every. So 6 and 10 yaad rakhna hai. 6 means you are supposed to have 6 groups of follicles and you are supposed to have 10 cells per group, and that is the adequacy criteria. However, every adequacy criteria will have an exception, and that exception is what? Number 1, if it's a colloid goiter, you will not see so many cells. You will only and only see colloid. So don't wait for so many cells to come up in front of you. Second, if you're seeing any cancerous change may, will you focus on the cancer or will you focus on the number? So the number is irrelevant. Even if I'm seeing one cell which is bad looking, I have to tell the clinician that, it is cancer. I don't care about the number, but if cancer is seen, I will tell you. And number 3, if there is any inflammation, for example, if it's a case of Hashimoto's thyroiditis, I will see thyroiditis, I will see a lot of itis, inflammation hoga. So then in that case, my focus is not going to be how many numbers am I seeing. My focus is that I have to give the diagnosis irrespective of the number. So for colloid goiter, CCI, colloid goiter, cancer and inflammation, I am not going to focus on the number. That is the FNSC criteria, right? So now focusing on the thyroiditis, and then we'll go on to the thyroid cancers. When I'm talking about thyroiditis, the first one is going to be Hashimoto's thyroiditis. Itis matlab inflammation. Which inflammation are you talking about? We are talking about lymphocytic inflammation. So why is this happening? It's an autoimmune disorder. There is going to be association with a lot of antibodies. For example, anti-TPO antibody, anti-thyroglobulin antibody. And in fact, why are these people making these antibodies? Because they have HLA polymorphisms, HLA DR3, DR5 polymorphism. So now my question to all of you is that how is this going to look like in the patient and the microscope? And then I'll tell you what are the risks present. I just called it lymphocytic thyroiditis. So I'm going to see lots of lymphocytes. This is how Hashimoto's looks like. First and foremost, the entire thyroid gland is enlarged. This is going to be a diffuse enlargement that we have over here. After that, you'll say, okay, first ma'am, can you tell me thyroid ka element hoga? So I can definitely see all these pink things. All these pink things are gonna be what? These are all thyroid follicles. Whereas what is this itis? Itis matlab inflammation. Kaunsa inflammation? I've already told you. The other name for Hashimoto's thyroiditis is lymphocytic infiltration. So lymphocytic matlab you're gonna see a lot of lymphoid. All these blue color cells are the lymphoid ones over here. So you will say that ma'am, I'm noticing that everywhere it is blue, it is all blue, but the center is looking a little whitish. Can you see that? The periphery is all blue. Yes, I agree. And the center is looking a little paler, a little whitish. Why? Because in lymphoid follicles, the center has germinal center. Matlab proper lymph node jaisa ban raha hai. It's almost making a proper lymph node out here, hai na? So please remember, Hashimoto's is going to show you lymphocytes and thyroid both combination. But what is said to be the hallmark of Hashimoto's thyroiditis, HHH? What is HHH? Hallmark of Hashimoto is going to be the Hurdle cells. It's going to be the Hurdle cells. So you can very well see these very dark pink cells that are present over here. These very pink cells are the Hurdle cells. So simple. Hashimoto shows you diffuse enlargement, lot of lymphocytes and lot of Hurdle cells. And because of this, now you will say again, split the word. थायराइड तो कुछ थायराइड का कैंसर हो सकता है एंड आइटिस इन्फ्लेमेशन लिम्फोसाइट्स तो कुछ लिम्फोसाइट्स का कैंसर हो सकता है. व्हाट इज लिम्फोसाइट्स का कैंसर? लिम्फोमा. सो दिस इज एट अ रिस्क ऑफ लिम्फोमा. एंड विच थायराइड कैंसर इज इट एट अ रिस्क ऑफ? Papillary carcinoma thyroid. So remember, thyroiditis is going to be at a risk of papillary carcinoma thyroid, and because it's lymphocyte, it is at a risk of a lymphoma, that is maltoma. Going on to the next, there is something known as de Quervain thyroiditis, and de Quervain thyroiditis is the only one out of these which is going to present with pain. This is the only and the most common cause of thyroid pain, painful thyroiditis. So de Quervain is a pain in the thyroid. So first you'll ask me two questions. Why does this happen? Why is there pain in the thyroid? So this is most commonly seen after a viral infection. So something like a mumps or something like an adenovirus infection, some kind of a viral infection is going to be noted. So this is seen post viral infection. And next, how is it going to look under the microscope? So you need to know the other name. This is known as granulomatous thyroiditis. It is a granulomatous thyroiditis, means I see granuloma. What is your concept of a granuloma? Granuloma means कि हमें मिलेगा giant cell. So exactly what I'm going to see over here is lots and lots of these giant cells. If I start seeing giant cells, means I'm talking about a granuloma. And if I'm talking about a granuloma, we are talking about de Quervain thyroiditis. Again telling you it's a pain. It's a painful thyroid. Coming to the next, the painless postpartum thyroid. What is that? The painless postpartum thyroid. So innocent after the delivery, and painless is subacute lymphocytic thyroiditis. Ratta hai. It's painless and occurs in postpartum women, subacute lymphocytic thyroiditis. Lastly, we have the one that I'm expecting. What is Riedel's thyroiditis? Riedel's thyroiditis is basically a thyroid condition in which there is a lot of fibrosis. There is so much of fibrosis that the thyroid starts looking like a stone. It's so hard to touch. And when it's so hard to touch, I start thinking, is it a cancer? This is the one that mimics a cancer. So now, obviously it's not a cancer, but because itna hard hota hai, the thyroid to touch is so hard, you feel it's a cancer. You know why is it happening? This is an update. It is now being classified as an IgG4 related disease. Anything with lots of fibrosis, they say fibrosis in the salivary gland, fibrosis in the thyroid, fibrosis in the retroperitoneum, all the fibrosing conditions are being put under IgG4 related disorders. Okay, so quick revision. This is all about your thyroiditis that you have, which is the one that can mimic cancer. It's the last one, that is Riedel's thyroiditis. And ultimately, what were they resulting in? They were all resulting in hypothyroidism. They were decreasing the activity of the thyroid gland, because now I'm going to tell you something that increases the activity of the thyroid gland, hyperthyroidism, and that is going to be Graves' disease. Graves' disease, known as the Basedow disease. It increases the activity of the thyroid gland. And how does it increase the activity? Of course, it has some antibodies. It is because of something known as thyroid stimulating immunoglobulins. It is because of thyroid stimulating immunoglobulins, some antibodies, immunoglobulins, some antibodies are there. They are stimulating the thyroid. They are telling the thyroid that do more work, make more T3 and T4. That is why it is resulting in hyperthyroidism. So how does it look like? Zyada kaam kar raha hai. Kaam kar karke it has become red. It has become red. So it is a beefy red thyroid which is overactive, working a lot. And because it is working a lot, you will see there are these, as if, you know, like an ice cream scoop you take and you take out ice cream, na? It seems as if someone is eating the colloid. So zyada kaam karo, zyada khana khao. So basically it is eating the colloid. Eating the colloid means it is scalloping of the colloid is seen. So please remember, it's a beefy red thyroid on fire. I'm going to tell you why am I calling it on fire. It is on fire. It is doing a lot of work, hyperthyroidism, and it is eating a lot of food. It is scalloping the colloid. And why did I say fire? Because when you do the FNAC, you will see fire flares. The thyroid is genuinely, when I say it's doing a lot of work, it is on fire. Means, can you see that there are these red, pink, red color flares? Fire flares are noted. So now coming back, the story is complete. Graves' disease is a beefy red overactive thyroid eating a lot of food, so scalloping of colloid, and it's genuinely on fire. It shows you fire flares on an FNAC. With that, we have completed our hypo and hyperthyroidism. Now I'm going to go on to a table and talk about, that is your summary of the different thyroid tumors that you have. So I've tried that my best that in all of this rapid review, I give you lots of tables so that your entire pathology becomes in a tabular manner. Otherwise, students usually have a complaint that, you know, bulk of notes is very difficult to read. Papillary on one page, follicular on one page. If you have everything on one page, mentally also you're quite settled that, you know, bas ek table hi to padna hai and the chapter is done. So mental satisfaction in the preparation of NEET PG and FMG actually makes a hell lot of difference. So here we have the 10 pages are put up into one. We start off with the most common, and that is papillary carcinoma. So what all do we have to know about papillary carcinoma? First, I'll ask you the risk factors. So please remember radiation. Go back to your neoplasia chapter. I have taught you which thyroid cancer occurs with radiation. It is papillary. Number 2, right now we studied Hashimoto's thyroiditis also can cause papillary carcinoma. And in your neoplasia chapter, I had told you 2 genetics. What are the 2 genetics? One is the BRAF mutation. So BRAF causes PCT. And RET PTC, RET PTC में तो the name is only there, papillary thyroid cancer, तो obviously it will cause papillary thyroid cancer. Repeating, BRAF mutation is going to be seen and RET PTC fusion is going to be seen. These are the two, but yeah, the most common will always be the BRAF mutation. Finally, what is its prognosis? Not only is it most common as a tumor, but God has given it the best prognosis. So this is not only best, I would say excellent, 100% survival, best prognosis that these patients have. Now I have to know what are going to be these pictures. These pictures I've got for your summary. I'm going to show it to you on a different slide so that you have a full spectrum ready in front of you. When we are talking about papillary carcinoma thyroid, remember the first word that you have to do justice to is papillae. So what I'm seeing over here is actually a lot of these finger-like papillae. What I'm seeing over here are a lot of these finger-like papillae. So papillae is one thing. And not only papillae, I would like to call them true papillae. These are said to be true papillae. Point number one. Point number two, we see all these empty white nuclei like the cartoon character, that is orphan Annie nucleus. And let me tell you, orphan Annie nucleus is a formalin artifact. It is because of formalin. It is not a real finding. It's a formalin-induced finding. Number three, if you look at the nuclei, you are seeing intranuclear cytoplasmic inclusions. So can you see inside the nucleus, I'm seeing a dot, means you're seeing inclusions. Number four, you see coffee bean nuclei. Yes, you can see the nucleus has a line going through it. It has a line going through it, matlab coffee bean nucleus. And number five, the very famous Samoma bodies, which everyone knows that papillary carcinoma shows. So coming back, true papillae with orphan Annie nucleus with inclusions with coffee bean appearance and Samoma bodies. Out of them, which is the one that you see only because of formalin? You see formalin ki wajah se orphan Annie nucleus. So all of these were what? These were all seen on biopsy. Is there something which you only see on FNAC? Anything that you only see on FNAC of papillary carcinoma thyroid is the very famous chewing gum colloid. Kyun? Because FNAC mein you have used a very thin patla needle, na? So needle mein the colloid gets stuck. The colloid gets stuck and then it becomes stretchy like this. So this chewing gum colloid is a finding which you see only on an FNAC. And that wraps up your main findings that you have to do. But if you're targeting some extra marks and अच्छे marks chahiye, then I'm going to tell you two more things from surgery point of view. Papillary carcinoma thyroid has some variants also. Fancy names. One is going to be the Lindsay tumor. One is the tall cell variant of papillary thyroid cancer. When I say Lindsay tumor, it is defined as the encapsulated, but before that it is solid. So it is the solid encapsulated follicular variant of papillary carcinoma thyroid. I know it's very tough to learn, but you will have to. Kya kare? Right? So we have solid encapsulated follicular variant of papillary carcinoma thyroid. That is going to be the Lindsay tumor. Means what? It is solid. It is not cystic. No cavity, no cyst. Solid tumor hai. It has a capsule also, and it's going to have round follicles. That is what it means. Solid encapsulated follicular variant of papillary carcinoma. Fancy name, examiner's favorite. That is Lindsay tumor. What is tall cell variant? Suddenly you will say, ma'am, the cells are very tall. Kitna tall? Height kitna hai? So you will say the length of the cells has become 3 times the width. So if this is the width x, then the length has to be 3x. So the length is 3 times the width. These cells are more than 30% in number. So 3 times width hai, 3 times is the length, and 30% is the amount. And all of these show BRAF mutation. BRAF mutation mandatory. You will say, anyway ma'am, for papillary carcinoma thyroid we were having BRAF mutation only. But iske liye tall cell variant ke liye to mandatory hai. Without it you can't give the diagnosis. So that wraps up your papillary carcinoma thyroid. Moving on to the next, follicular carcinoma. If someone asks you what is the most common mutation that you see out here, that is the RAS mutation. Most common is the RAS mutation, and one thing which is very important to know, all the PP things are gonna come. Matlab, it is gonna show you P10 mutation, PPI3K mutation, PAX8, PPAR gamma mutation. So jitna bhi PP things are going to come under follicular carcinoma. But again, asking you which is the most common? RAS mutation is the most common. Something which is different out here. This is the only thyroid cancer which is known to have a hematogenous spread. Baki to carcinoma is always going to lymphatics, na? But this is a one which is going to be hematogenous spread. This information is very important. So how do you do the diagnosis? What are these two pictures for follicular carcinoma that I've given to you over here? Please remember, for follicular carcinoma thyroid, number one, we have to see capsular invasion. Capsular invasion matlab, you can see there is a capsule over here, and a capsule over here, and it's broken. Look at it again. This capsule here and this capsule here is broken. Someone is coming out through the capsule. So capsule invade ho gaya. Second, if this is a blood vessel, so I'm also seeing blood vessel invasion, vascular invasion. Someone is going into the blood vessel. Cancer cells are going and sitting in the blood vessel. So what are the two findings for follicular carcinoma? We first have to see capsular invasion, and then we also have to see vascular or angio invasion. Coming to the next, medullary thyroid cancer. If you all remember, there was a mnemonic, RET 10 med men. Can you repeat that for me? What is RET 10 med men? RET is going to be the gene. 10 is going to be that RET gene is present on 10 chromosome. Med is going to be the tumor, that is medullary carcinoma thyroid, and men is going to be the syndrome. So the syndrome is going to be men 2A and men 2B. So repeating once again, RET 10 med men. So RET is the gene, 10 is the chromosome that it's present on, 10 is the chromosome. Medullary carcinoma thyroid we are doing, and it is going to be a part of men 2A and men 2B. So your next question is that what is going to be the tumor marker? The tumor marker, we all know the most famous is calcitonin. CEA bhi hota hai, but calcitonin is most famous. And from calcitonin, what is formed? Amyloid ban jayega. Which kind of amyloid? A-cal is formed. So what is this picture? Repeating once again, when I'm saying that the tumor marker is calcitonin, from calcitonin the amyloid that will form will be the A-cal type of amyloid. So for amyloid, do I know one very famous stain that we apply? The Congo red stain. So three questions. What is the stain for amyloid? Congo red stain. Which microscopy and what appearance? Apple green birefringence. On which microscopy? On polarizing microscopy. So again, which is the only thyroid cancer which can show you apple green birefringence on polarizing microscopy is medullary carcinoma. Coming to the last one. So ho gaya, RET 10 med men ho gaya, calcitonin and tumor marker and apple green birefringence. Coming to the one which has the worst prognosis in the end, worst, which is rapid progression, rapid death, and aplastic. So that wraps up all of your 4 thyroid cancers. Papillary and follicular and medullary get you most questions. Anaplastic rare hai, but worst hai. That is what you have to know. Sorted? Done with the thyroid. The next organ which we are going to pay attention to is going to be the adrenal gland tumors. What are the 2 adrenal gland tumors that you have to focus on? I'm starting first with neuroblastoma, then I'll come to pheochromocytoma. When I say neuroblastoma, one thing about neuroblastoma that all of you know is that it shows you the very famous Homer Wright pseudo rosette. So I've taught you this earlier also. Dekho, what is this rosette? You are going to see these blue color rosette, round cells. And what are they covered with, or what are they going to have? They are going to have the pink material. So please remember, Homer Wright pseudo rosette is going to be seen over here in a case of neuroblastoma. And where else did you study? Remember, we had a mnemonic, men are right or men are fake. Men are right or men are fake. So basically for men we had studied N aa gaya yahan pe, neuroblastoma. One more blastoma in the brain, medulloblastoma, also shows you the same thing. And something in the bone, Ewing sarcoma. Ewing sarcoma also shows you the tumor. So remember, men, medulloblastoma, Ewing sarcoma, neuroblastoma. Men are right, men are fake. So that is what you see as Homer Wright pseudorosettes. Now, the question that you get is, which I've taught you in neoplasia chapter, neuroblastoma shows you which amplification. So neuroblastoma shows you N for N. It shows you N-mic amplification, and that carries a very bad prognosis. So they are going to ask you, what are the prognostic factors that you have for neuroblastoma? Which are the prognostic factors which are going to be good, and which are the prognostic factors that are bad? So remember, neuroblastoma is a bachon wala tumor. So till the time it is happening in very tiny kids, it is good. But when it starts occurring in older people, I'm a little worried. Above 18 months, I'm worried. Next, when I use the word blastoma, blastoma reminds me of blastocyst, blastema, basically kuch chota bacha, yolk sac, fetus wala thing it. But when I say things are getting differentiated, when I say things are maturing, that a nerve is forming, Schwann cell is forming, ganglion cell is forming, so maturation is the good. Now, if I say you've matured in life, that's a good sign. So when this tumor has matured in life, this means it is a good sign. Next, remember, anything that is going to be a lot. For example, if I say DNA ploidy hyperdiploid, hyperdiploid something more, that is good. TRKA mutation, TRKA, A is a lot, A matlab acha, so anything that is a lot is acha, A for acha, so TRKA is good, TRKB is gonna be bad. Simple. Having a lot of chromosomes is acha, having losses, having less number of chromosomes is bad. So basically having a lot of things is acha, having AA is acha. So what do I say? Having AA is acha, TRKA is acha, B is gonna be bad. Similarly, having lots of chromosomes is acha and having loss of chromosomes is gonna be bad. The only thing that you have to know, NMIC. NMIC is bad. NMIC is something that you see in neuroblastoma and NMIC is considered bad. This was all about neuroblastoma. Bas yaad rakho that you're going to see an adrenal gland tumor with this kind of Homer right pseudorosettes. All the a lot things are going to be acha. The AA things are going to be acha. The BB things and the losses are going to be bad. Maturation is acha and bachon ka tumor hai. Let it be in the bachas. That is also going to be good. Now, the only thing is N for N. It shows you NMIC mutation. NMIC mutation is said to be bad. So, one thing is done. The next tumor that you have to go and study is going to be pheochromocytoma. You know the rule of 10? Exactly. 3 slides. How to finish pheochromocytoma in 3 slides for the exam and crack every question possible. Today, I will tell you. When I say rule of 10, I know pheochromocytoma tends to occur in the adrenal gland. Na? But if I say rule of 10, matlab, which how many adrenal glands? 10% of them are going to occur in both the adrenal glands. 10% of them will occur in children. 10% of them will occur outside the adrenal gland, and when they occur outside the adrenal gland, that is known as paraganglioma. 10% of them will spread, malignant. 10% of them do not cause hypertension. This means pheochromocytoma is very famous for causing 3 things: hypertension, tachycardia, as well as sweating. It is very famous for increasing the BP, increasing the heart rate and causing sweating. So, ye to usual hai because pheochromocytoma releases what? It releases catecholamines. Na? Catecholamines will cause hypertension. So, only 10% of them don't cause hypertension. So, repeating, 10% of them, rare cheezein 10% hai. 10% of them are bilateral. 10% of them will occur in chota bachas, children. 10% of them will occur outside the gland. 10% of them will spread outside the gland. 10% of them will not cause hypertension. Earlier, it was said that 10% is familial, not now. Now, they are saying 25% is familial. This has changed. Now, 25% is familial. So, you will ask me, what are the genetics that are associated with familial pheochromocytoma? So, ab rule to I can't change. Na? Although they have changed. They have said 25% of them are familial, but my mnemonic still remains 10. Means, what is the gene present on chromosome 10? We had just studied RET is present on 10. So, when I write 10, one gene that is coming to my mind, 10 ke saath, is going to be the RET gene. So, RET gene is going to run in the families. After that, if I see that there is some E written over here. This means there is a EPAS gene that is running in the family. Then, dusra E I have written like a 3 because 3p deletion tells me I am dealing with VHL syndrome. So, that is written over here. N will remind me of NF1 syndrome, that is written over here, and S will remind me of succinate dehydrogenase, that is also written over here. So, repeating, if I am talking about 10 say RET, E say EPAS gene, 3 for VHL, N for NF1, S for SDH. This is not important for FMG, even NEET, okay. INI CET ke liye this is very important, okay. So, the rule of 10 is even followed when the rule of 10 is not followed. Matlab, although it is not 10% familial, now it is 25% familial. So, even when I am not following the rule of 10, indirectly my mnemonic is 10 only. These are the genetics that you have. So, I told you na, we will finish pheochromocytoma in 3 slides. Exactly, I am keeping my promise. 3 ka 4 ho sakta hai, thoda sa. But first I told you it's a rule of 10 which we've done. In that rule of 10, I told you that these are all the genetics which are now 25%. So, let's consider this as one slide. This rule of 10s are done. Now, I go on to the next slide. Next slides are going to show me all the microscopic analysis. So, jaldi se let us finish off. When I talk about the microscopic analysis, this shows you the very famous nesting or Zell-Bellin pattern. You will be able to see nests like this. You see nesting or the Zell-Bellin pattern. Very famous question that you get for pheochromocytoma because nesting pattern to is seen many places. But the word Zell-Bellin is given to it only over here. Zell-Bellin for pheochromocytoma. So, now you will want to ask me, what are these nests going to have? These nests are going to have some cells in the center. These center wala cells are known as the chief cells. And do you know chief cells are the real neuroendocrine cells? Because we know pheochromocytoma is a neuroendocrine tumor. Na? So what is the immunohistochemistry going to be? Okay, brown color stain, immunohistochemistry, all the neuroendocrine markers will be positive in the chief cells. Because the main chief principal cells, they are the neuroendocrine cells. Whereas I have some cells which are on the side. These are, I can call them as supporting cells. These are known as supporting cells. Supporting cells are known as sustentacular cells and they are S100 positive. So SSS ho gaya. Sustentacular cells are supporting cells, and which immunohistochemistry am I seeing over here? What is this brown chota color that is coming? That is the S100. So they will ask you this question, and they have asked you in the previous year in NEET. Sustentacular cells are positive for which marker? So you will say sustentacular cells are supporting cells and they are S100 positive. Whereas the main wala chief cells, they are going to be neuroendocrine. So what am I saying? It's a neuroendocrine tumor. So what is the electron microscopy going to show you? Every neuroendocrine tumor shows you the same electron microscopy, and that is the neurosecretory granules. All electron microscopies show you the same. Neurosecretory granules are going to be noted. And now finally, one last slide. What is the tumor marker? We know the catecholamines or the metabolites, that is metanephrines. Metanephrines are going to be the tumor marker. So like I said, 3 points about pheochromocytoma. You should know the rule of tens and the familial genes. You should know the microscopy, the sustentacular cells especially, and you should know the tumor marker, which is going to be the metanephrines. We've wrapped up on that, and now we can quickly do 2 more slides. One is to do with the genetics of the pituitary tumors, and one is going to be the slide on the MEN syndrome. Having discussed the thyroid and the adrenal gland tumors, now you need a 5-minute quick discussion of pituitary tumors and the MEN syndromes. Pituitary tumors are more or less important if you're targeting the INI-CET exam, not at all important for the FMG exams. You can take a skip on that in case you're preparing for FMG. So please remember, for pituitary gland tumors, you have what all? You have adenomas in the pituitary gland, you have carcinomas in the pituitary gland, and blastoma. So you will get a genetics question on it. Pituitary carcinoma is HRAS. If you go back to the neoplasia chapter, we have studied that in HRAS mutation, from one H you make the kidney, so it's important in kidney cancer, and from the other limb of H you make pituitary carcinoma. So HRAS pituitary carcinoma already done in neoplasia chapter. Pituitary blastoma shows you dicer mutations, dicing, as if you're dicing something, so dice karoge to blast hoga. Remember that Fruit Ninja game that used to come? Fruit Ninja, fruits used to come on the screen, you used to dice it, and the fruit used to, that watermelon used to blast. So whenever you will dice something, there's going to be blast, right? So pituitary blastoma shows you dicer mutations. After that, now you don't particularly have to know that which one causes which particular adenoma where you are talking about, but they ask you that which are the ones which are going to be associated with somatic activating mutations, which of them are activating mutations and which of them are inactivating mutations. Means somatic activating mutations and germline inactivating mutations. So please note that all the things that have the letter S in it are somatic inactivating. Matlab HRAS has S, it is somatic inactivating. USP8 has an S, that is somatic inactivating. GNAS has an S, so that is somatic activating. So everything that is somatic S is activating. Okay? S wali things are somatic, and everything other than S, so CDK, N1A, dicer, or you can say this PRKAR and AIP, these are all going to be germline inactivating mutations. Simple. So sirf SS wala pick up kar lena, they are all somatic activating mutations. Simple. So yes, that is what wraps up. That is all that you had to know about pituitary tumors. Like I said, this one short table only for INI-CET, it's important. Now what is important that you guys have to know are the different MEN syndromes. What are MEN syndromes? It is multiple endocrine neoplasia. Multiple endocrine, the word only tells me that the patient is going to have many tumors of the endocrine system. Multiple endocrine neoplasias, which is MEN 1, 2A, 2B. Earlier 2A, 2B were separate. It used to be 2 and 3, but then they said, nahi, genetics to same hai, to call it 2 only. MEN 1, MEN 2A, MEN 2B and MEN 4 has come up. Let me first tell you the genetics only. MEN 1 is basically a problem in the menin gene. MEN 2A and 2B are a problem in Rett gene, out of which please remember, MEN 1 is also known as the Wermer syndrome and MEN 2A is known as the Sippel syndrome. right? So remember, men 1 is a menin problem, men 2A, men 2B, that is why they are said to be limbs of 2A, 2B, because both of them have a Rett problem. And men 4 is CDKN1B problem. The genetics is different, but ultimately we realized that men 1 and men 4 were showing very, very common features. Most of the features were common between them. Only thing is that the genetics is coming across as different. So, you know, what is the features that I'm talking about? Please note that I have to first know the mnemonic. तो men 1 के लिए तो I have made a mnemonic, everything is PA, PA, PA. The rule is you have to find PA everywhere in every tumor that I'm going to tell. तो men 1 के लिए तो PA, 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 that is first thing. For men 2A and men 2B, what have I learned? You are a small kid, a tiny kid, imagine, and you have to ask for money from your parents, right? So you have to pay for some school fee or some tuition fee or some coaching classes fee. So what are you going to do? So first you'll ask your father for money. Papa, give me the fees, right? If your papa doesn't give you the fees, then you'll ask your mother for the fees. So mama, give me the fees. That is how I have learned, you know, these men syndromes. So papa, give me the fees, and mama, give me the fees. So how am I going to finish this table? Now let's fill in the blanks. When I'm talking about men 1, I told you PA, PA, PA. So PA for pancreatic tumors, okay? Then PA for parathyroid hyperplasia, PA for pituitary adenoma. You know what problem happens? Pancreatic tumor तो याद हो जाता है, that's not a problem. Kids get confused between parathyroid का क्या था? Parathyroid का adenoma था या pituitary का adenoma था या किसका hyperplasia था? So remember, only one P and one A can occur. So if parathyroid में PA has already come earlier ना, so adenoma cannot come here now. Only one PA can come, and parathyroid में P and A दोनों आ चुका है, so hyperplasia has to be fit in over here. Pituitary में only P came. That is why I could use the A for the adenoma. Really took me a lot of time to come up with this mnemonic. It's a tough one. So please remember, PA for pancreatic tumor, PA for parathyroid, already A aa chuka hai, so I can't put adenoma, I'll have to call it hyperplasia, and pituitary adenoma fits in well. Okay, that is men 1. Men 2 is what? Papa give me fees. What is Papa give me fees? Again, PA के बाद adenoma cannot come. PA मतलब parathyroid hyperplasia. Give me मतलब medullary carcinoma thyroid. And fees मतलब pheochromocytoma. So parathyroid hyperplasia, then medullary carcinoma, then pheochromocytoma. Papa doesn't give you fees, then you ask for mummy for the fees. So what is mama give me fees? MU is going to be mucosal neuromas. Then you have marfanoid habitus. Again, medullary carcinoma same पहले की तरह, pheochromocytoma same पहले की तरह. So basically, give me the fees remains the same. Whether you're asking from papa or mama, that is going to change. So papa का हो गया parathyroid hyperplasia, and mama is going to be mucosal neuromas and marfanoid habitus. Men 4, like I told you, is going to be very similar in terms of clinical symptomatology to men 1. Only the genetics is going to be different, and we've done the genetics as well. Yes, on that note, our endocrine system also comes to an end. Thyroid, adrenal, men syndromes, pituitary, all of that is done. And yes, you are sorted with this also.